Welcome back to the Charcos Academy learning series on nursing management of substance use disorders. This is Module 4, Treatment Modalities and Pharmacotherapy. In the previous modules, we built the foundation, understanding what substance use disorder is, recognizing clinical presentations, and conducting systematic assessments. Now, in Module 4, we shift to treatment. We will explore the continuum of care, learn about FDA-approved medications for alcohol and opioid use disorders, understand evidence-based psychotherapies, and discover how medication-assisted treatment transforms outcomes. This is where assessment turns into action, and where your nursing care can truly change lives. By the end of this module, you will understand the treatment options available and your role in supporting patients through their recovery journey. By the end of this module, you will be able to 1. Describe the continuum of care and treatment levels for substance use disorders. 2. Explain FDA-approved medications for alcohol and opioid use disorders. 3. Understand evidence-based psychotherapy approaches, including CBT and motivational interviewing. 4. Recognize the principles of medication-assisted treatment, or EMAT. 5. Support patients with co-occurring psychiatric conditions. 6. Implement relapse prevention strategies. 7. Apply nursing considerations for medication management. These are practical, actionable skills that you will use in hospitals, clinics, residential treatment facilities, and community settings. Treatment for substance use disorder is not one size fits all. Instead, we use a continuum of care model, where treatment intensity matches severity of the disorder. Let me walk you through the levels, from least to most intensive. Outpatient treatment. This involves 1 to 2 hours per week of individual or group counseling. It is best for patients with mild to moderate substance use disorder, who have stable housing and a strong support system. Intensive outpatient program, or IOP. This requires 9 or more hours per week, typically 3 days per week for 3 hours each day. It is best for patients with moderate substance use disorder who need more structure. Partial hospitalization program, or PHP. This involves 20 or more hours per week, typically 5 days per week for 4 to 6 hours each day. It is best for patients with severe substance use disorder who need daily monitoring but are not at immediate medical risk. Residential or inpatient treatment. This provides 24/7 care, typically for 30 to 90 days. It is best for patients with severe substance use disorder, medical complications, or unstable housing. Medically managed intensive inpatient. This is hospital-level care with medical monitoring. It is best for patients experiencing acute withdrawal or those with severe comorbidities. Your nursing role: help assess the appropriate level of care and support transitions between levels as the patient progresses. Treatment typically progresses through 3 phases, regardless of the level of care. Phase 1, acute stabilization. This phase focuses on detoxification, medical stabilization, crisis intervention, and safety planning. The goal is safe, comfortable withdrawal. Phase 2, early recovery. This phase focuses on intensive psychotherapy, medication initiation, skill building, and lifestyle changes. The goal is establishing abstinence and developing recovery skills. Phase 3, sustained recovery. This phase focuses on relapse prevention, medication maintenance, therapy, peer support, and reintegration. The goal is long-term wellness and prevention of relapse. Important: treatment is not linear. Relapse may occur. This does not mean failure, it means treatment needs adjustment. Now let's discuss pharmacotherapy for alcohol use disorder. There are 3 FDA-approved medications. 1. Naltrexone. This is an opioid antagonist that reduces alcohol cravings and the pleasure associated with drinking. 2. Acamprosate. This modulates the glutamate system and reduces post-acute withdrawal symptoms. 3. Disulfiram. This is aversion therapy. It causes a very unpleasant reaction if alcohol is consumed. Important principles: these medications are adjuncts to psychotherapy, not standalone treatments. They work best when combined with counseling and support. Research shows they increase abstinence rates. Unfortunately, they are underutilized. only about 10% of eligible patients receive them. Your role as a nurse is to educate patients about these options and support adherence. Let's start with naltrexone. Mechanism of action. Naltrexone is an opioid receptor antagonist. It blocks the release of endogenous opioids that are released when a person drinks alcohol. By blocking these receptors, naltrexone reduces the high or pleasure and decreases cravings. Formulations. Oral naltrexone, Revia, 50 mg once daily tablet. Injectable naltrexone, Vivitrol, 380 mg intramuscular injection once monthly. Dosing. Naltrexone should be started after the patient has been abstinent for 7 to 10 days to avoid precipitating opioid withdrawal. Nursing considerations. Check liver function before starting. Ensure the patient is opioid-free for 7 to 10 days. Monitor for depression and suicidal ideation. Patient education. Explain. This medication reduces your urge to drink and makes drinking less rewarding. It's like turning down the volume. Common side effects: nausea, headache, fatigue. Now let's discuss acamprosate. Mechanism of action. Acamprosate modulates the glutamate and GABA neurotransmitter systems in the brain. Chronic alcohol use disrupts the balance between these systems. Acamprosate helps restore that balance. It is particularly effective at reducing post-acute withdrawal symptoms such as anxiety, insomnia, and dysphoria. Dosing. Acamprosate is dosed as 666 mg 3 times daily. It can be started during detoxification or immediately after withdrawal. Advantages: no hepatotoxicity, it is safe in liver disease, no abuse potential, there is no risk of misuse. Nursing considerations: the 3 times daily dosing can be challenging for adherence. Acamprosate is renally excreted, so it should be avoided in severe kidney disease. Patient education. Explain. This medication helps your brain chemistry rebalance. It reduces the anxiety and sleep problems that make it hard to stay sober. Side effects: diarrhea, nausea, and headache. Now let's talk about disulfiram, which works very differently from naltrexone and acamprosate. Mechanism of action: disulfiram inhibits the enzyme aldehyde dehydrogenase, which is responsible for breaking down acetaldehyde, a toxic metabolite of alcohol. When a person on disulfiram drinks alcohol, acetaldehyde accumulates rapidly, causing a very unpleasant reaction. The antabuse reaction occurs 10 to 30 minutes after alcohol ingestion and lasts for hours. Symptoms include flushing and throbbing headache, severe nausea and vomiting, chest pain and palpitations, hypotension and weakness, anxiety and confusion. In severe cases, the reaction can cause arrhythmias, seizures, and even death. Dosing: 250 to 500 mg once daily. The patient must be completely abstinent when starting disulfiram. Nursing considerations. Informed consent is essential. The patient must fully understand the consequences. Check liver function. Educate about hidden alcohol sources, such as mouthwash, cough syrup, cooking wine or vinegar, hand sanitizer, and some topical preparations. The reaction can occur up to 14 days after the last dose. Disulfiram is best for highly motivated patients. Some programs use supervised administration. Your nursing role: ensure informed consent, provide education, and monitor for side effects and adherence. Now let's shift to opioid use disorder and medication-assisted treatment, or MAT. MAT is the gold standard for treating opioid use disorder. It combines medication plus psychosocial support. There are 2 main FDA-approved medications for opioid use disorder. 1. Methadone, a full opioid agonist, dispensed only in licensed opioid treatment programs, OTPs, requires daily supervised dosing, at least initially. 2. Buprenorphine, a partial opioid agonist, can be prescribed in office settings by certified providers, reduces withdrawal and cravings without producing euphoria. Also used: naltrexone, an opioid antagonist, given as a monthly injection. The patient must be opioid-free for 7 to 10 days before starting. Why MAT works? MAT reduces withdrawal symptoms, decreases cravings, and blocks the euphoria from illicit opioids. It allows patients to stabilize and engage in recovery activities. Most importantly, MAT reduces overdose death by 50% or more. This is life-saving treatment. Let's discuss methadone in detail. Mechanism of action. Methadone is a full mu opioid receptor agonist. It is long-acting with a half-life of 24 to 36 hours, so it can be dosed once daily. Methadone prevents withdrawal, reduces cravings, and provides cross-tolerance, meaning it blocks the high from other opioids. Dosing, starting dose, typically 20 to 30 milligrams daily. Maintenance dose, 60 to 120 milligrams daily is the most effective. Titrate slowly over weeks. Regulations: methadone can only be dispensed in licensed opioid treatment programs. Patients must come for daily observed dosing initially. Demonstrated stability can earn take-home doses. Nursing considerations: QTC prolongation is a serious risk. ECG is required before starting and periodically. Assess for sedation and monitor respiratory rate. Be aware of drug interactions. Benzodiazepines are particularly dangerous. Patient education. Methadone is treatment, not trading one addiction for another. Address stigma, support their dignity, advantages. Very effective with comprehensive services. Disadvantages: daily clinic visits can be a barrier. Stigma remains a significant issue. Now let's discuss buprenorphine, which has revolutionized access to opioid use disorder treatment. Mechanism of action. Buprenorphine is a partial mu-opioid agonist and a kappa antagonist. As a partial agonist, it activates opioid receptors, but only partially. This means it prevents withdrawal and cravings, does not produce euphoria at therapeutic doses, has a ceiling effect on respiratory depression, making it much safer than methadone or full agonist opioids. Buprenorphine also has high receptor affinity, meaning it binds tightly to opioid receptors and displaces other opioids. Formulations: buprenorphine alone, Subutex. Used primarily in pregnancy, as naloxone has not been fully studied in pregnant women. Buprenorphine plus naloxone, Suboxone. This is the standard formulation. The naloxone is added to prevent intravenous misuse. If someone injects Suboxone, the naloxone is activated and causes precipitated withdrawal. However, when taken sublingually, under the tongue, as prescribed, the naloxone is not absorbed and has no effect. Dosing. Induction. Day 1. 8 to 16 mg sublingual. Induction must begin when the patient is in mild to moderate withdrawal, typically 8 to 12 hours after last opioid use. Starting too early causes precipitated withdrawal. Maintenance. 12 to 24 mg daily. Some patients do better with split dosing, twice daily. Prescribing. Buprenorphine can be prescribed in office-based settings by providers who have completed training and obtained a waiver, previously called the DATA 2000 waiver, now streamlined. Prescriptions are given for home use, just like other medications. This dramatically increases access compared to methadone. Nursing considerations. Timing of the first dose is critical. The patient must be in withdrawal before the first dose. Use the COWS scale. A score of 8 to 12 or higher indicates readiness. If buprenorphine is given too early, it will displace other opioids from receptors and cause precipitated withdrawal, which is extremely unpleasant. Administration technique. Place the tablet or film under the tongue and let it dissolve for 5 to 10 minutes. Do not swallow. Monitor for precipitated withdrawal in the first hour after the first dose. Signs include sweating, dilated pupils, agitation, and severe discomfort. Educate about safe storage. Buprenorphine can be fatal to children if accidentally ingested. Store in a locked, child-proof container. Common side effects: headache, nausea, constipation, and sweating. Now let's discuss naltrexone for opioid use disorder. We already discussed naltrexone for alcohol use disorder. It is also used for opioid use disorder, though less commonly. Mechanism of action. Naltrexone is an opioid receptor antagonist. It blocks opioid receptors completely, preventing euphoria if the patient uses opioids. It has no potential for misuse because it is not an opioid. Formulation: Vivitrol, 380 mg intramuscular injection once monthly. This is the preferred formulation for opioid use disorder, as adherence is ensured. Oral naltrexone is available, but is less commonly used for opioid use disorder due to adherence challenges. Requirements: The patient must be opioid-free for 7 to 10 days before starting naltrexone. This is a major barrier, as achieving 7 to 10 days of abstinence is very difficult for most patients. Naltrexone is often used after inpatient detoxification or after release from incarceration, when the patient has already achieved abstinence. Nursing considerations. Precipitated withdrawal is a risk if any opioids are in the patient's system. Always verify with urine drug screen and clinical assessment before each injection. Patients lose tolerance while on naltrexone. If they relapse and use opioids after discontinuing naltrexone, they are at very high risk of overdose because their tolerance has decreased. Patient education. Explain. If you try to use opioids while on this medication, you won't feel anything. The medication blocks the effects. Warn about the overdose risk if they relapse after stopping naltrexone. Advantages: no potential for misuse, once monthly dosing, no daily clinic requirement. Disadvantages: achieving 7 to 10 days of abstinence is a major barrier. Loss of tolerance creates overdose risk if patient relapses. Now let's shift from pharmacotherapy to psychotherapy. The most researched and widely used therapy for substance use disorder is cognitive behavioral therapy, or CBT. Core principle. CBT is based on the idea that thoughts, feelings, and behaviors are interconnected. By changing thoughts, we can change feelings and behaviors. CBT for substance use focuses on 1. Identifying triggers. Triggers are people, places, emotions, or situations that lead to craving or use. Common triggers include stress, certain social situations, seeing drug paraphernalia, or feeling bored or lonely. 2. Challenging automatic thoughts. These are the immediate, often unconscious thoughts that lead to use. For example, I can't handle stress without drinking, or just one won't hurt. CBT teaches patients to challenge these thoughts and replace them with healthier alternatives. For example, I've handled stress before without drinking. I can use deep breathing or call my sponsor. 3. Developing alternative coping skills. Patients learn and practice new ways to cope with triggers and cravings, such as exercise, calling a support person, deep breathing, or distraction techniques. 4. Practicing refusal skills. Patients learn how to say no when offered substances and how to remove themselves from high-risk situations. 5. Building problem-solving strategies. Patients practice identifying problems, brainstorming solutions, evaluating options, and implementing solutions. Structure. CBT typically involves 12 to 16 weekly sessions. It is structured and goal-oriented, with homework assignments between sessions. The focus is on current problems and future prevention, rather than exploring the past in depth. Evidence. CBT is the most researched psychotherapy for substance use disorder. It is effective for alcohol, cocaine, cannabis, and other substances. The skills learned are durable, benefits persist after treatment ends. Your nursing role: reinforce CBT concepts during interactions, help patients identify triggers on the unit or in the clinic, encourage practice of coping skills. Another essential approach is motivational interviewing, or MI. Philosophy. MI is a patient-centered, non-confrontational approach that recognizes ambivalence is normal. Most people with substance use disorder feel both a desire to change and a desire to continue using. This is called ambivalence. MI recognizes that change comes from within. You cannot force someone to change. The therapist's role is to guide, not direct. Core principles, the 4 R's. 1. Resist the righting reflex. Don't tell the patient what to do or lecture them. Resist the urge to fix them. 2. Understand the patient's motivations. Explore their reasons for change, not your reasons. 3. Listen empathetically. Reflect back what you hear without judgment. 4. Empower the patient. Support their autonomy and belief in their ability to change. MI techniques: open-ended questions. What concerns you about your drinking? Affirmations: it took courage to come here today. Reflective listening: it sounds like you're worried about your health, but you're not sure you're ready to quit. Summarizing: pull together what the patient has shared, highlighting their own motivations for change. Evidence: MI is particularly effective for increasing treatment engagement and reducing resistance. It works well in early stages when the patient is unsure about change. Nursing application: use the spirit of MI in all patient interactions. Avoid lecturing or being judgmental. Ask permission before giving advice. For example, would it be okay if I share some information about treatment options? Group therapy and peer support are cornerstones of substance use disorder treatment. Why groups work: reduce isolation. Patients often feel alone in their struggle. In a group, they realize, I'm not the only one. Peer feedback. Hearing from others with lived experience is often more powerful than hearing from a professional. Modeling. Patients see others succeed and learn from their strategies. Accountability. Making commitments to group members increases motivation. Cost effective. Groups reach more people at lower cost than individual therapy. Types of groups. Psychoeducational groups teach about substance use disorder, health effects, coping skills, and recovery. Process groups focus on sharing experiences, giving and receiving support, and working through emotions. Skills training groups practice specific techniques, such as communication skills or stress management. 12. STEP programs, AA and NA. Alcoholics Anonymous, AA, and Narcotics Anonymous, and NA, are free peer-led support groups available worldwide. They follow a 12-step program based on spiritual principles. The concept of a higher power is central. Though it can be defined individually, it does not have to be God. Key elements include sponsorship, a mentor in recovery, regular meetings, and working the steps. Evidence. Participation in AA or NA is associated with better long-term outcomes. Not for everyone. Some people do not connect with the spiritual focus. That's okay. There are alternatives. Other peer support options. Smart Recovery, a science-based secular program with no higher power requirement. Refuge Recovery, a Buddhist-based approach. Online communities, especially helpful for people in rural areas or during the pandemic. Your nursing role: encourage participation in groups. Help patients find meetings in their area. Normalize peer support as part of recovery. Family therapy addresses the reality that addiction affects the entire family system. Why family therapy matters? Families often develop unhealthy patterns in response to a member's substance use, such as enabling, codependency, or emotional cutoff. The family can be the patient's greatest support or the greatest barrier to recovery. Many patients relapse when they return to unchanged family dynamics. Goals of family therapy. 1. Educate the family about addiction as a medical condition, not a moral failing. 2. Identify and change enabling behaviors. Enabling includes shielding the person from consequences, making excuses, giving money that may be used for substances, and taking over their responsibilities. 3. Improve communication and problem-solving skills within the family. 4. Address family trauma and resentment that has built up over time. 5. Build healthy boundaries. Family members learn to say no and take care of themselves. 6. Create a recovery-supportive home environment. Common family roles in addiction. The enabler shields the person from consequences, makes excuses. The hero tries to make the family look good, overachieves. The scapegoat acts out, diverts attention from the real problem. The lost child withdraws, gets overlooked. The mascot uses humor to deflect tension. Family education topics. What is addiction? A brain disease, not a choice. What is enabling versus supporting? Self-care for family members. Al-Anon and Nar-Anon. Support groups for families of people with addiction. Your nursing role. Encourage family involvement in treatment. Provide education. Refer to family therapy and family support groups. Co-occurring disorders, having both a substance use disorder and a mental health disorder, are the rule, not the exception. 50 to 75% of people with substance use disorder have a co-occurring mental health disorder, such as depression, anxiety, PTSD, ADHD, or bipolar disorder. Integrated treatment is essential. We must treat both conditions simultaneously. Untreated depression or anxiety leads to relapse. Continued substance use worsens psychiatric symptoms. Common medications for co-occurring conditions. For depression, SSRIs, selective serotonin reuptake inhibitors, such as sertraline, fluoxetine, and escitalopram are first line. Avoid tricyclic antidepressants in active substance use, as they are dangerous in overdose. For anxiety, SSRIs are also effective for generalized anxiety disorder. Avoid benzodiazepines if possible, as they have addiction potential and are dangerous when combined with opioids or alcohol. Consider non-addictive alternatives such as buspirone or hydroxyzine. For ADHD, stimulants such as methylphenidate or amphetamines can be used, but with caution and close monitoring for misuse. Non-stimulant options are often preferred in active substance use disorder: atomoxetine, Strattera, or bupropion, Wellbutrin. For bipolar disorder, mood stabilizers such as lithium, valproate, or lamotrigine. Avoid benzodiazepines for agitation. For PTSD, SSRIs such as sertraline and paroxetine are FDA approved for PTSD. Prazosin can help with nightmares. Nursing considerations: monitor adherence. Substance use can interfere with taking psychiatric medications. Assess for medication interactions. Patient education. Explain that psychiatric medications are not replacing the substance. They are treating a separate condition that may have contributed to the substance use. Let's briefly review medications used for withdrawal management, which we touched on in Module 2. Alcohol withdrawal. Benzodiazepines are the first-line treatment. Common options include lorazepam, diazepam, and chlordiazepoxide. Benzodiazepines prevent seizures and delirium tremens, which can be fatal. Use symptom-triggered dosing based on the CIWA-R scale, which is more effective than fixed dose schedules. Thiamine, vitamin B1, must be given to prevent Wernicke-Korsakoff syndrome, a potentially irreversible brain disorder. Supportive care, IV fluids, electrolyte replacement, magnesium, potassium, phosphate, and multivitamins. Opioid withdrawal. Comfort medications for symptomatic treatment. Clonidine for autonomic symptoms. Sweating, anxiety, elevated blood pressure. Loperamide for diarrhea. Ondansetron for nausea. NSAIDs for muscle aches. Or use buprenorphine, which controls all withdrawal symptoms and transitions the patient to maintenance treatment. Or use methadone in a licensed clinic setting. Benzodiazepine or sedative withdrawal. Gradual taper of the same benzodiazepine or an equivalent. Never stop abruptly, seizure risk is high. Sometimes phenobarbital is used for multi-substance detoxification. Stimulant withdrawal. No specific medications are required. Supportive care, rest, nutrition, hydration. Monitor for depression and suicidality, which are the main risks. Relapse is common. Relapse rates are 40 to 60%, similar to other chronic diseases like diabetes or hypertension. But relapse is preventable, and when it occurs, it is an event, not a failure. The 3 stages of relapse. 1. Emotional relapse. The person is not thinking about using, but they are setting themselves up for relapse. Signs: poor self-care, isolation, not attending meetings, bottling up emotions. Intervention: return to basics, sleep, nutrition, meetings, talking about feelings. 2. Mental relapse. The person starts thinking about using. Signs: glamorizing past use, thinking about people or places associated with use, planning a relapse. Intervention: play the tape forward, remember the consequences of use, call a sponsor, attend a meeting. 3. Physical relapse. The person actually uses the substance. Intervention: return to treatment immediately. Don't spiral into prolonged use. Relapse prevention techniques: identify high-risk situations, use the acronym HALT: hungry, angry, lonely, tired. These are common relapse triggers. Develop coping skills for each trigger. Build a sober support network. Sponsor, therapist, supportive friends and family. Engage in meaningful activities, work, hobbies, volunteering, exercise. Avoid people, places, and things associated with substance use, especially in early recovery. Medication adherence: naltrexone, buprenorphine, or acamprosate Reduce relapse risk. Ongoing therapy and 12-step or peer support participation. Your nursing role: help patients create a written relapse prevention plan before discharge. Include warning signs, triggers, coping strategies, and a list of support contacts. Certain populations have unique needs in substance use disorder treatment. Pregnant women. MAT is recommended for pregnant women with opioid use disorder. Buprenorphine or methadone are both safe and effective. Withdrawal during pregnancy is dangerous for the fetus. Neonatal abstinence syndrome, NAS, occurs when a baby withdraws after birth. It is treated with supportive care and sometimes medication. Integrated prenatal care plus addiction treatment improves outcomes. Adolescence. The adolescent brain is still developing, making it especially vulnerable to the effects of substances. Family involvement is critical in adolescent treatment. Treatment should address school, peer relationships, and developmental tasks. Screen for trauma and co-occurring disorders, which are very common. Elderly. The elderly are an often overlooked population. Substance use disorder in the elderly often involves prescription medications prescribed for legitimate reasons, pain, insomnia, that become problematic. Risk factors include isolation, grief, chronic pain, and multiple medications. The elderly have increased sensitivity to medications and higher risk of falls and cognitive impairment. Incarcerated individuals. The justice system has very high rates of substance use disorder. MATI in jails and prisons dramatically improves outcomes and reduces overdose deaths after release. Re-entry planning is essential. Connect to treatment and support before release. Healthcare workers. Healthcare workers have access to medications and knowledge of their effects, putting them at risk. They face professional consequences. Fear of losing their license creates shame and delays treatment. Most states have confidential programs specifically for healthcare workers. With appropriate support, healthcare workers have high recovery rates. LGBTQ+ individuals. LGBTQ+ individuals have higher rates of substance use, often related to minority stress and discrimination. Treatment must be affirming and inclusive. Let's consolidate what we've learned in Module 4. Remember, treatment levels match severity: outpatient, IOP, partial hospitalization, residential, medically managed inpatient. 3 phases of treatment: acute stabilization, early recovery, sustained recovery. Alcohol medications: naltrexone reduces reward and cravings. Acamprosate balances brain chemistry. Disulfiram causes aversion. Opioid MAT: methadone is a full agonist, clinic-based. Buprenorphine is a partial agonist, office-based. Naltrexone is an antagonist requiring abstinence first. MATI equals medication plus counseling, not medication alone. Psychotherapies. CBT changes thoughts and behaviors. MI builds motivation. Group therapy provides peer support. Family therapy heals the system. Co-occurring disorders are the rule. Treat both simultaneously. Relapse prevention involves recognizing the 3 stages: emotional, mental, physical, identifying triggers, and building coping skills and support. Special populations need tailored approaches: pregnant women, adolescents, elderly, incarcerated, healthcare workers, LGBTQ+. In the next module, Module 5, Nursing Interventions and Rehabilitation, we will focus on nursing-specific actions: nursing diagnoses, care planning, therapeutic communication, acute care interventions, discharge planning, and self-care for nurses. Thank you for completing Module 4. Your understanding of treatment options empowers you to advocate for and support your patients. When you are ready, proceed to Module 5.